Hi friends, I am Dr. B.V. Rao of Usha Clinic and founder of the websites qmedicaldoubts.blogspot.com and raghavamedicaldoubts.com. Through these videos, I am providing the basic knowledge about the commonly occurring diseases, treatment and surgery details when necessary for the medical knowledge to general people and for reference to medicals. Today I am going to discuss about the post-maturity in pregnancy. The duration of pregnancy is not definite and precise. Using the standard NAEGELE'S rule in determination of the expected date of confinement called EDC, it is said to be 280 days or 40 weeks. Using this criterion, it is found that about 12% of pregnancies extend beyond 294 days. However, doubt has been cast upon these data by recent work where the length of gestation is calculated following artificial insemination or with the use of basal temperature charts to determine the time of ovulation. In case of artificial insemination, the average duration of pregnancy is 272 days, while in basal temperature case 260 to 270 days. In some cases, the pregnancy have lasted 349 days if computed on menstrual data alone. In such instances, the long gestations were attributed to delayed ovulation and subsequent fertilization. The women who menstruate at shorter intervals than 28 days may expect their confinement earlier than those with longer cycles. The usual criteria employed for estimating the maturity is calculation from the menstrual data, growth of uterus, date of quickening, size of fetus or calculated but with errors. More reliable method of estimating maturity of fetus are described as cytological examination of amniotic fluid. It is helpful in assessment of fetal maturity in complicated pregnancies. The method is based upon the staining of lipid containing cells in amniotic fluid with Nile blue sulfate. The lipid containing cells or fat cells which are exfoliated into amniotic fluid originate in the fetal sebaceous glands, and the number of fat cells found reflects accurately the development and increasing maturity of fetus. The technique is mixing 1 or 2 drops of amniotic fluid obtained by puncture per abdomen on a glass slide with equal amount of 0.1% Nile blue sulfate solution. The slide is allowed to dry for 5 minutes at room temperature and 500 cells counted and classified. The fat cells are usually stained orange to brown, either ovoid or polygonal in shape, and present in varying numbers depending on the duration of pregnancy. This test is a useful guide to fetal maturity in the last 4 weeks of pregnancy. The fat cell count of over 10% is met with only when pregnancy is beyond 36 weeks. As the pregnancy advances, the percentage of fat cells continue to increase, usually reaching about 20% at 38 weeks and 50% at 39 to 42 weeks. This method is therefore a valuable guide in assessing fetal maturity. Estimation of creatinine liquor amnii. It suggested that amniotic fluid in the third trimester is largely a product of the fetal kidney. This is due to the increase in number of functional glomeruli and to the proper establishment of tubular function. It is therefore expected that as the fetus matures, a substance as creatinine, which is completely filtered at the glomeruli and is not reabsorbed by the tubules will be found in increasing amounts in amniotic fluid. Amniotic fluid creatinine increases in a linear fashion with advancing pregnancy. The creatinine content of liquor is always higher than that of the maternal serum. The mother of 37 weeks have a liquor creatinine of 1.72 milligrams per 100 ml, and by 41 weeks it is 2.74 milligrams per 100 ml. If liquor amniotic creatinine content is 1.5 milligrams per 100 ml or more, duration of pregnancy is seldom less than 34 weeks. If the value of 2.2 milligrams per 100 ml or more, the duration of gestation is 38 weeks or more. Recently, it is possible to measure biparietal diameter of fetus in utero by means of pulsed ultrasound. This has made it possible to construct a growth curve for the biparietal diameter. It seems to be possible by ultrasonic measurement of biparietal diameter when a patient will go into labor. Cases have been reported with prolonged pregnancy up to 337 days. Some found it is associated with encephalic fetus. It is necessary in diagnosing prolonged pregnancy that the fetal heart sounds are audible some days after term. Those cases where the fetus dies in utero before term and is delivered some weeks after term should not be considered as cases of post-maturity. Experimentally, pregnancy can be prolonged beyond the expected date by injecting progesterone. During prolonged pregnancy, characteristic changes are seen in fetal organs, especially endocrine organs. These changes are hyperemia, edema, and regressive cellular changes. They are marked before intrauterine death of fetus. Histologically, a rapid development and severe degeneration of placenta as a whole could be detected. Hyalinization takes place and the placenta becomes small, pale, hyalinized amniotic fluid is scanty and sometimes fetid. The umbilical cord is shrunken. The cause of the intrauterine death of the fetus during post-maturity was thought to be due to cessation of placental function towards the term. The assumption was supported by regressive changes in the placenta in the later stages of pregnancy. It has also been found that the progesterone values in the placenta were higher than normal. Probably the comfortable surroundings, sedentary life, scanty exercise are said to be the cause of prolonged gestation. Elderly primipara and multipara are said to have post-mature mothers' children. Diagnosis. It is difficult to find out abnormal size of the fetus, which can be easily recognized because of oligohydramnios. The rate of growth of uterus. Characteristics of fetal skull on palpation. The condition of cervix. Test induction with oxytocin, which may not respond to oxytocin induction. Radiography. Presence of ossification centers of os capitatum and os hematum is said to be diagnostic of post-maturity. Hazards to mother and child. There is a higher perinatal mortality rate in post-mature cases. Intrauterine death of fetus due to anoxia of labor or the common causes. Some causes are related to difficult labor and delivery. The average Parietal mortality is about 7.4%. Management. Those who do not believe that it is a clinical problem treat it on the same lines as a normal one. The problem of a big child is tackled on the lines of disproportion. Those who believe in post-maturity and the dangers of inherent in it believe that no pregnancy should be permitted to continue beyond the fortnight after the due date. If the patient does not get into labor by then, labor is induced after careful assessment of the pelvis and disproportion. Among the hospital group of patients, it is difficult to assess the duration of pregnancy due to lack of details. Once we are convinced that the fetus has reached term, we induce labor within 10 to 14 days if the patient has not gone into labor spontaneously by the time. We are partial to the use of oxytocin drip and artificial rupture of membranes for this purpose. In absence of any other complications like elderly primiparity, disproportion, toxemia, etc., we do not respond to elective cesarean section. If in labor fetal distress supervenes, cesarean section is resorted to. That's all about the post maturity, and in the next video I will discuss about some other disease. Thank you.